Moving on to the next session, I am pleased to introduce Dr. Pablo Moreno Franco, who is the chairperson of the Department of Critical Care Medicine at Mayo Clinic, Florida, and Critical Care Specialty Council across the Mayo Clinic enterprises. He is also Associate Medical Director of Quality Academy and an Associate Professor in Medicine. And Dr. Pablo was honored as a Diamond Quality Fellow for his outstanding contributions to quality improvement. He leads several quality initiatives focused on enhancing patient care and safety at Mayo Clinic. His area of interest are science of healthcare delivery and acute care research consortium, and his research interests include sepsis and septic shock care and delirium prevention, ECMO, ARDS management, ICU resource utilization, liver transplantation, and ECMO life support. Over to you, sir. And sir is going to present pre-ECMO patient management and optimization.
Hello, I'm Pablo Moreno Franco, the chair for critical care medicine at Mayo Clinic in Florida and also across the enterprise. My passion is quality improvement, so I'm an associate medical director for our teaching academy, which is a quality academy for improvement. So today we're going to talk about the pre-ECMO patient management and optimizations. I have no disclosures. If you would like to contact me, you can use this QR code, which is my Linktree contact. You can find different social media accounts to ways to get a hold of me. I have no disclosures, and ECMO is largely off-label use, and that is what we will be discussing today. As learning objectives, we'll talk about how to better assess patients for suitability for ECMO candidacy. We'll also talk about the pre-ECMO care in terms of optimizing the condition. If it is, for example, VV ECMO that we're considering, how we can use rescue strategies, optimize the fluids, manage with other therapies like antibiotics. If we're considering VA ECMO, we'll also discuss about cardiac optimization, shock staging, and how to assess for coronary artery disease or acute coronary syndrome. Importantly, we always have a multidisciplinary team thinking about ECMO candidates before we actually deploy the technology, which is very important in terms of teamwork and communication, not only between us, but also with the family, and we can explain to them the possible outcomes and the particular trajectory. There are many dilemmas when we are considering ECMO. The most important decision that you'll make is whether or not to cannulate and put the patient on ECMO, because it's a very resource-intense situation, and it's easier than ever to initiate and maintain, but we have to make sure that we succeed most often than not. And in those cases, we don't want to put patients that are non-salvageable in ECMO therapy. We also want to make sure we incorporate patients that are neurologically intact or have a reversible condition or could be candidates for exit strategies such as transplantation. We want to make sure that the appropriate conventional therapies have been exhausted, there's no terminal condition present, and all the possible comorbidities are being considered, as well as resources, consents, finances, etc. There are many prediction models out there regarding who will survive if ECMO is used, but many of these are older models and they're not necessarily applicable to the current technology that we have. So in that regard, we know that these models are available, we know how to calculate them, but most of the time we're using more clinical gestalt and multidisciplinary discussion to make that decision regarding whether or not to cannulate. In terms of pre-VV ECMO checklist, we want to make sure that we cover the patients need to be optimized from intravascular volume. There's appropriate inotropic support that should be given, as well as all the rescue strategies, either ventilatory or non-ventilatory, should have been done. For example, sometimes people get really excited about giving more PEEP and more PEEP to the point that it could be detrimental, and sometimes you just see those patients just by decreasing the PEEP, things improve. So we want to make sure that those things are covered, that there's whether or not there's evidence of adequate tissue perfusion or oxygen delivery, and to see if we can prevent the spiral to multi-organ dysfunction. In terms of refractory hypoxemia, there are many ways to treat these patients. More commonly, we are talking about ARSNet protocols in terms of high PEEP, low tidal volume, but there are other ventilatory strategies like APRV or recruitment maneuvers that could be utilized. High frequency oscillatory ventilation has gone out of use based on some studies that were done in Canada within the last decade. And then prone positioning is certainly something that we use frequently. We know that proning for more than 14, 16 hours improves outcomes. And then in terms of other vasodilatory therapies, pulmonary vasodilatory therapies, we have either nitric oxide or inhaled prostacyclins that could be used before we actually pull the trigger on ECMO. So if we get a call to evaluate for VV ECMO initiation, again, we're looking at whether or not there's a terminal disease present, there's non-neurologically catastrophe that we need to be aware of, and then we consider things like anticoagulation, functional status. Then we look at the ventilator, make sure that that has been optimized, the PF ratio, and then see if the patient has had rescue strategies like proning, paralysis, inhaled pulmonary vasodilatory therapies, if the patient needs to be diuresed, etc. So if there is a very elevated lactate, particularly be aware of lactates of more than 12 for more than 12 hours, that could be potentially a bad sign of declining multi-organ function. So that needs to be taken into account as well. It also recommends that as we are evaluating, so to put it in very simple terms, if we're only facing respiratory failure and we're not concerned about the heart, then we can quickly move to VV ECMO. But if we are concerned about the heart function, or if the patient has severe pulmonary hypertension, then we're going to have to consider VA ECMO. Also understanding that these two may need to be worked hybridly. So there are patients that are going to be on a combination of VV and VA based on their primary situation. The indication changes, and that indication kind of determines how elective or urgently we need to cannulate. So for example, a lot of times for VV refractory hypoxemia, we can do it, electively and have a lot of time to have these conversations. But sometimes we have things like post-trauma or post-cardiotomy that are more urgent. And in those cases, we need to make the decision quicker. But in any of those cases, we need to have the multidisciplinary discussion regarding the goals that we're trying to achieve predominantly, and also discussion with the family regarding the prognosis and to get proper consent for this therapy. Respiratory failure, as we know it, particularly when we get to the stage of refractory hypoxemia, which we're going to define together here in a couple of minutes, carries a high mortality, and that is why it's important to determine if there's any reversibility and responsiveness to optimal conventional strategy. If not, then we need to move to ECMO, particularly if we think the mortality is higher than 50%, and certainly if it is greater than 80%. But how do we know that? So most commonly we use criteria like the PF ratio. So for example, PF ratio less than 150 or a Murray score from 2 to 3 is associated with 50% mortality, and a PF ratio of less than 100 and a Murray score of 3 to 4 is associated with 80% mortality or more. So this is typically what we use, and you'll question, well, what is the Murray score? So this was published in the 1980s, and essentially it's a combination of PF ratio, chest X-ray, PEEP, and compliance. So by using all these data, we can determine the degree of refractory hypoxemia. So for example, in terms of chest X-ray, we look at how many quadrants are affected. In terms of PEEP, it goes from 5 to 15, and compliance you can also see from greater than 80 to less than 20. And in those cases, you'll see that we can better predict who is going to recover or not, and who needs to be considered for VV ECMO. At our institution, what we typically do when we are seeing refractory hypoxemia is aggressively manage that patient with conventional strategies, particularly if we get to a PF ratio of less than 0.7, FiO2 of greater than 70, or a PF ratio of less than 100, then in those cases we consider prone positioning. If they cannot be prone, we're talking about ECMO. If they can be prone, we give that a trial, and if it fails, we'll still consider for ECMO. Now see that the ECMO consultation is earlier, even before APRV or inhaled prostaglandins, because the idea here is to make sure that the ECMO team can have time to evaluate and make a decision whether or not they're candidates before we waste too much time and then it's too late for them to go to ECMO. We also need to consider if the patients have any irreversible chronic respiratory failure. So in those cases, we need to think if the patient is a candidate for lung transplantation, in which case ECMO may still be indicated, but if they're not considered for transplant, then they may not be candidates for ECMO as well. We also need to understand the management of patients that have cardiogenic shock or cardiac failure, and they could be with or without hypoxia. So to do that, we typically follow a checklist that includes looking at the hemodynamics, understanding what the coronary artery disease is and if it has any that could be fixed. We also look at the rhythm that the patient has. We try to understand the contribution of the right ventricle in this dysfunction, utilizing echocardiogram and pulmonary artery pulsatility index. And in majority of the cases, we have a cardiogenic shock team activation, so we can make a decision regarding possible cannulation. The ELSO guidelines really talk about looking at tissue perfusion overall, and if there is hypotension and low oxygen delivery, then we know we're facing shock. And then if that shock persists despite volume and inotropes, then we are now in the space of cardiogenic shock and considering what could be done in terms of mechanical circulatory support. There was a nice study published by the SKY group, which essentially helped us with defining the different stages of cardiogenic shock, called A, B, C, D, and E. And that really talks about the patient that is at risk at the beginning of cardiogenic shock, or the classic cardiogenic shock, or deteriorating beyond that, or if they're extremists. And that helps us then make the decision of how quickly we have to move regarding mechanical circulatory support. There are some absolute contraindications, and we need to be aware that the patient is not going to be a candidate for heart transplant or VAD, or they have advanced age or chronic diseases, or they have poor compliance issues or prolonged CPR. They may not be a candidate for ECMO. And there are also some relative contraindications, particularly related to ability to anticoagulate, the age, and presence of obesity. We take into account some of these, especially thinking about cannulation in terms of peripheral vascular disease or obesity, and we also have to think about some aortic valve issues or aortic dissection that could complicate the picture. We always, before we deploy the mechanical circulatory support, we try to define which ventricle is affected mostly, right, left, or both, and I'm going to show you how we do that in our institution. Try to get the team to the bedside as quickly as possible so we can determine what mechanical support is needed and treat any possible arrhythmias. In our institution, we use the Stage, Page, and Engage platform. So what it means is in the EMR, we've built an alert that determines the SKY categories A, B, C, D, and E. So you can see, for example, this patient was a cardiogenic shock stage B. That triggers a page alert that goes to our rapid response nurses, and then we start a conversation. They call us. We do some particularly laboratory studies to try to assess for shock. We do an ultrasound at the bedside, and then if necessary, based on the results of those and the interventions, then we may call a cardiogenic shock tier, in which a number of individuals join a Zoom call and we have a conversation regarding which mechanical circulatory support should be deployed for that particular patient. So as an example, we follow this idea that if the patient has cardiogenic shock with a low cardiac power output, we determine if it's mostly right ventricular, in which case they'll have a low pulmonary artery pulsatility index, elevated right atrial pressure, and a low wedge, then we know we're facing an RV predominant. If they have hypoxia, then we go for VA ECMO. If they don't have hypoxia, we could consider RV support only. If it's a left ventricular predominance, sometimes we can get away only with the impella, but also if there's hypoxia present, then we need to consider VA ECMO. And lastly, if it's a ventricular dysfunction, again, we look at the degree of hypoxemia. If it's not bad, we could try bipella or Protect Duo, or we can also go to VA ECMO. Importantly, even after we put the mechanical support, we still have to continue to follow hemodynamics, because sometimes we have to change the mechanical support strategy or cannulation strategy. Survival after VA ECMO, it's difficult to predict, but there's some nice scores like the SAFE score that takes into account all the categories that you see in the right, and these are the better ways we have to predict survival. But again, most of the time we're also thinking, is this a patient somebody who can be transplanted or could have an LVAD support long term. It's always important before we put the patients on ECMO that we have a very good conversation with the family regarding prognostication. Not everybody can do really well, like this patient that is leaving the hospital after a long run. Some patients do not do well, and it's important to set the expectations and have the conversations with the family regarding that, and then keep them, regular updates. We tend to have palliative care consultation in all our ECMO patients, just as a rule, and that helps with clarifying the expectations, the communication, and make sure that there's informed decisions and common shared goals. With that, we'll close. We'll thank you for your attention. We know that ECMO, it's a very important technology. It's not for everyone, so it should not be automatic that every critically ill patient gets this. We need to have a very elegant protocol to define who needs which degree of support, VV ECMO versus VA ECMO versus other mechanical circulatory support devices, and the best way to do that is in a multidisciplinary team. Set those goals of therapy, reassess often, discuss the prognosis with the family, not only at the beginning but throughout the hospital stay with multidisciplinary discussions, and then keep the family in the team so that we all have a unified voice. So with that, we'll close. We thank you for your attention. We're open for questions, and to do that, you can send those to me via email. You can see the email on the screen, or you can contact me again through Linktree, and you'll see there my different social media accounts. So I'm happy to answer the questions that way as well. We thank you for your attention and wish you all the best in your training and your future ECMO management.